Welcome to Menopause Rescue. I'm Dr. Polly Watson. Midlife women are often caught up in a sea of symptoms. Too often, they're overwhelmed by the lack of support from mainstream healthcare. They're inundated with so-called experts who are selling solutions which may lack credibility. I'm a Menopause Society certified gynecologist with both traditional and functional medicine training. I'm here to guide you through this transition and help you decipher the facts from the fads. Armed with credible information, I hope you are empowered to rescue and restore your health, making the second half of your life your best. I'm so excited to be able to share this conversation with Dr. Felice Gersh. We had a great conversation, and I think we could have talked for hours. We spoke for about an hour, so we're going to divide it up into two parts. In this first part, Dr. Gersh really outlines and clarifies for us the difference between bioidentical hormones and non-naturally occurring hormones, and really makes clear the difference between these in terms of cardiovascular health. The next thing we're going to tackle is really addressing current dosing guidelines when it comes to cardiovascular health, and talk about what we know based on science versus what we have studies to support. Join me for this really fun conversation with Dr. Felice Gersh. I'm Dr. Polly Watson, and I'm so excited to have Dr. Felice Gersh with me today. This is a big fangirl moment for me, so I'm really glad to be with you. Dr. Gersh is a well-known hormone expert. She's double board certified in both OBGYN and integrative medicine, and she's been awarded Orange County Medical Association's Physician of the Year for the last 16 years, and it got a Super Doctor Award in Southern California. She's the author of 3 books, PCOS SOS, PCOS Fertility Fast Track, and Menopause 50 Things You Need to Know. She's published many articles, one of which we're going to discuss today and link in the show notes, that was on estrogen and cardiovascular disease, which was published in Progress in Cardiovascular Diseases in January of this year. So thank you so much for joining us today.
Well, it's such a pleasure. Thank you so much for inviting me.
One of the things you start off with in this article that was recently published this year, and a lot of your articles, which is such an important distinction to be just really clear with people, is the difference between bioidentical estrogens and progesterone, and for instance, a non-bioidentical like conjugated equine estrogen and a progestogen. So I think so often we're talking about hormone replacement therapy, and we're sort of putting a bunch of different chemicals in one bucket, and it makes it really confusing to understand risk and benefit. So can you just clarify for people the differences between those two groups of chemicals?
Yes, because it has created massive chaos in the literature as well. In fact, even in some of the most prestigious medical journals, the authors are throwing around these words like they're all the same things. And my analogy that I started with once upon a time was saying, like, you do a study with strawberry flavored jelly beans, and it didn't really turn out too well. You ended up having more cavities, diabetes, and obesity when you used those strawberry flavored jelly beans. And the conclusion reads, never eat an organic strawberry. It's that insane when you actually make conclusions based on something you didn't even study. So in many of the studies, not just the Women's Health Initiative, but others, and there haven't been anywhere near enough, they are not using human bioidentical hormones, or they're using them in a way that isn't going to get into the bloodstream, where they maintain their status as bioidentical to the human-made hormones because they get altered through digestion, metabolism of the liver, and so on into a different product. And so it makes it just crazy. Everyone now, I believe, knows that fats are not identical, that if you did a dinner where every food was manufactured, ultra-processed, containing trans fat, that the people that were consuming all those meals made with that garbage really would not end up being very healthy. In fact, they have done much data collection on that. And that is totally different than if you fed people the finest quality olive oils and wild salmon. We'll say, we'll keep the mercury out of this conversation. But, they have the best omega-3 or wild sardines, and you give them avocados and fresh organic walnuts and all of these fats. I mean, they're different. So it's so crazy. So the Women's Health Initiative, which was the big study that involved like the transformation of thinking about hormones for women in a very, very detrimental way, utilized what you had mentioned, conjugated equine estrogens. Conjugated means these hormones have gone through the liver and been biotransformed into a different product so that it could be eliminated through the urine. It transforms them from fat soluble to water soluble. And so it's part of the process of the equine, that's a horse, getting rid of this old, not wanted anymore, estrogen product that is totally unique to a pregnant horse, not just a female horse, but a pregnant horse. And that is then powderized. It comes out the urine. It's powderized, made into a tablet, and then fed to human females. Well, back in the day, decades ago, that was all that people could come up with to help women who were transitioning and in the early or even later stages of menopause, who were immensely suffering from night sweats and hot flashes and just in horrible state. And they had nothing else to offer. Even though it isn't a human product, it actually can still cross species help to reduce those terrible symptoms. So I'm not saying it's evil. I'm just saying it was in the time the best they could come up with. Well, that isn't true any longer. And it turned out that they also used what was actually a fake product in terms of it's not human progesterone, which has the letter P, capital P and a 4. That's human progesterone. It is a made-up thing with a made-up word called a progestin, which is just a made-up mimic, but not identical, just a bad mimic for progesterone called medroxyprogesterone acetate. Well, it has the word progesterone in it, but it is not the same molecule. And it has a different effect on the receptors such that it's what we call an agonist/antagonist. So agonist means it activates the receptor. Antagonist means it blocks the receptor. So depending on what organ and so forth, it can have either a super effect as a powerful progesterone or an anti-progesterone. So the bottom line is this combination created a bad overall effect. However, amazingly, it wasn't even as bad as it first was published to be, because when they reevaluated it, they found that even this ridiculous combination nowadays was actually beneficial in women who were in the 50s, who were like not too far out into menopause, and they were in their 50s. In fact, they found a reduced all-cause mortality, meaning that they died less of basically everything by 30%. There's no drug that reduces mortality by 30%. So it actually turned out to be beneficial in that group. Now, for older women, the average age in that study was 63. It went all the way up at the beginning to 79. And they said healthy. They weren't healthy. Where'd they find thousands and thousands of women in their 60s and 70s who were all in immaculate health status? Of course they didn't. So they had high cholesterol, hypertension, obesity. They were on pharmaceuticals. So it was really not a study of healthy women because they couldn't find them. And so it was a study of just women in that age group, typical women. And what did they find? Well, it turns out that the conjugated equine estrogen increases the risk of spontaneous, inappropriate blood clotting by fourfold. So if you take unhealthy women and aging when you don't have hormones and obesity, which is typical, that goes along with aging and not having hormones and the American way and so on, that those are all factors for increasing blood clotting. So this added like fuel to the fire for blood clotting. So if you're unhealthy and then you substantially increase risk of blood clotting, you could end up with a stroke, a thrombotic embolus. You could have DVT, deep vein thrombosis. You could have a heart attack. So there was some increase in blood clots, like deep vein thrombosis and strokes. They actually didn't find an increase in heart attacks when they did a reevaluation of the data. And it's sort of a nutty thing. In fact, the breast cancer issue, which has been so incredibly harmful in creating fear in women, what they found was that the conjugated equine estrogen, as bizarre as this is, actually lowered breast cancer incidence. And when they looked at like years and years later, this is a study that never dies. They keep reevaluating these same women, 10 years out, 15 years out, now 20 years out. And of course, they were on these hormones, whatever you want to call them, that were not human appropriate now 20 years ago. I mean, but they're still reevaluating them, and they're finding the women who are on just the conjugated equine estrogen have lower incidence of breast cancer compared to the general population. And what was really the bad part as far as breast cancer, and even that was very minimal, about the same as being on birth control pills, which nobody ever talks about at all as a risk factor for breast cancer or cervical cancer, which it is was small. It was like a little over 20% increased risk. And it was the medroxyprogesterone acetate, the fake mimic for progesterone, that actually was the etiology for this little increased incidence of breast cancer. But yet the people who produced this study, the lead investigators and all, they should be yelling from the rooftops, we made a mistake. But they won't, because their reputation, their entire career was built on a house of cards, on this really unfortunate study. It had a few good components, but the vast majority of the conclusions were inappropriately utilized. The conclusions should have been applied only to the product studied, but it was not. It was a broad stroke painted on every kind of hormone product. It set women's health back by so far 20 years and counting. And now they've done some studies, and they found that the majority of healthcare practitioners across all spectrums, nurse practitioners, PAs, EOs, MD, naturopaths, the people who are able to prescribe hormones, the vast majority of those practitioners were not practicing in any form, or they were too young, and they weren't practicing any form of medicine when the Women's Health Initiative came out. So their medical education was based on this false understanding of negativity surrounding hormones and female bodies and health across the entire spectrum of female organ systems. And it's actually now quite a small percentage of doctors who were actively practicing prior to and then through the thinking transition with the Women's Health Initiative. And the previous thinking, which was prior to the Women's Health Initiative, was very pro-hormone. All of that is lost. Like I feel like I'm one of like the last one standing that remembers how hormones were touted as good and wonderful, in fact, for women's health. Like, I wouldn't say the fountain of youth, but kind of, and but not wrongly so. And then it was like 180-degree turn. And the people who came through their medical education after the Women's Health Initiative were basically indoctrinated with this thinking of, if you have to use hormones for terrible symptoms like night sweats and hot flashes, because these are evil hormones, the natural hormones are evil. Like, they're all evil. Like the word estrogen is like a pariah, and they're evil. And so if you have to use them, like you absolutely must, then you would want to use the smallest possible dose for the shortest possible time. And even though there's been a little transformation, like the Menopause Society, formerly the North American Menopause Society, which I canceled my membership when the Women's Health Initiative came out. I was like a big supporter until they ended up perpetuating for ages, and still to some degree, the false conclusions of the Women's Health Initiative. So they were not pro women's health at all. They just echoed the same false refrain of hormones are bad, they're bad for you, use the tiniest dose, shortest duration. And now in their position statement that first was transformed into what it now is back in 2007, adds a little caveat that you can use them indefinitely with, observation and like surveillance, still giving the impression that, well, they're kind of on thin ice, but if you really want to, you can, for this nebulous thing, which I do appreciate that they stuck in there, called quality of life. That at least that opened the door for the practitioners like me who've been doing it anyway
Right.
to now have a sort of a green light that a medically established society and accepted society is endorsing, not wholeheartedly, but half-heartedly, but saying it's okay if you're super cautious, you kind of keep an eye on everything, that you could stay on them for quality of life indefinitely. So I appreciate that, but I still haven't rejoined. There are too many women that were harmed
Yes.
by them. And I appreciate that they've a little bit changed, a little bit, but I do not forgive and forget.
This is a great segue because you've set up a lot of really important themes. The really shift in thinking prior to the WHI were that hormones are really good for you, particularly estrogen was really good for your heart, right? And so that's something that you've written a lot about and been really clear in the distinction between bioidentical progesterone does in relation to estrogen, beneficial effect on the heart, versus a synthetic progestogen, which kind of undoes a lot of that benefit. So I think this is a good kind of segue to sort of talk about cardiovascular prevention and hormone replacement therapy. We know from the KEEPS trial where they looked at a 0.05 estradiol patch and 12 days a month of bioidentical progesterone, they didn't see as overwhelming as a response as we might have expected to see. And you brought up a really important point about that with dosing in that study and looking at blood levels and where blood levels maybe should be to provide some cardiovascular protection. So can you talk to us a little bit about once we've kind of shifted to the correct set of hormones, where should our doses be for heart protection?
Well, of course, we have limited data because nobody's collecting data. But when you think about it in a certain way, it will all sort of make sense. I think at this stage, everybody would agree that exercise is good for people. Everyone
Absolutely.
would agree that sleep is important. Everyone would agree that eating fresh fruits and vegetables, organic fruits and vegetables, are really good for people. And nobody would argue that there is a dose relationship. Like, for example, if you exercised for 10 minutes once a month, you wouldn't expect to see anything. If you ate one serving of vegetables a month, if you slept 2 hours a night, but it was good sleep for 2 hours. No, so everyone would agree that all things that are agreed to be truly very for health are dose related. By the way, they admitted this in the KEEP study. They admitted that they were influenced by, the unfortunate Women's Health Initiative and their pronouncement of the lowest dose is the best dose. That influenced these doctors who put together the KEEP study. Now, the doctors who put together the KEEP study, I give them A for effort, but I do not give them A for outcome. I cannot, because they were cardiologists. They really did not understand the hormones they were testing. Could not have, because they gave a dose and then they measured the levels and they stayed in the menopausal range. The levels that were achieved with the patches were actually in the same range that if you just randomly tested women of that age group that they were studying, they would be in that same range. And you could say, well, how could that be? That's because the estrogen patch, when it was developed back in the day, was developed when the thinking was kind of like less is best, less is best. So they didn't make patches that went up into very, very substantial doses. And the 0.05 was sort of the typical dose that was used, but it was very nominal in terms of what it achieved in terms of actual levels circulating in the blood. But here's a good thing and a bad thing. The amount of estrogen, and I'm saying estrogen, but it's estradiol.
Right.
Estradiol, and I'll just touch on that in a moment, what we're talking about when I say that. But the amount that was given, was enough that if a woman had night sweats and hot flashes, they could be significantly reduced. It turns out that, like I said, for good or bad, depending on how you think about it, it takes almost just a whiff of estrogen to suppress those symptoms. But that's not the same as having optimization of all the organ systems, and we'll focus on like cardiovascular. We do know from data, because there's almost no data. That's the sad thing. After the Women's Health Initiative came out, we had like the KEEP study, which was done inappropriately. It also used not just the 0.05 milligram estradiol patch. Premarin, conjugated equine estrogen, was still part of that study in a smaller dose than what was used in the Women's Health Initiative, which was 0.625. In the KEEP study, they used 0.45 because their mantra was still, let's give a lower dose, because lower is better. It would be like, why don't you eat fewer vegetables, exercise less? It will help you. When you put it in that context, it really seems absurd, because why would you want less of something that is highly beneficial? Well, that's because they really didn't believe in their hearts, studying hearts. They didn't believe that it really was going to be beneficial. So they got the outcome that they got because they used, the wrong product again, and a very small dose of the conjugated equine estrogens, and then they used a patch that didn't get a decent dose. And so everything is dose related. There is data showing that unless you get a serum estradiol level over 50, you'll have no effect on vaginal tissues. For some reason, well, you figure it out, I guess, the vagina has been the target of most data collection. This is like a huge thing in the menopause society now, is the genitourinary syndrome of the menopause, which is talking about vaginal health and bladder health and the basic sort of pelvic floor area, that is involved in things like incontinence and so on. So that's their big focus. And they say they're recommending every woman at every age, no matter how far out she is from when she was in, going through menopause, that they all get vaginal estrogen. Okay. But only vaginal estrogen. That's like where the big push is. And so we have data that shows levels for vaginal health. Okay. But let's make a very reasonable assumption. If it's not helping the vagina, why would I think it's helping something else? Okay. Sure. Because the whole body kind of sinks or swims as a unit, right? Mm-hmm. So you have to have a level over 50, and they didn't reach that. Yeah, it's not going to help your arteries. Sorry, just not going to do it. Plus, better for worse, women who are young, close to the menopause, typically are still living what I call it the halo of hormones, that they still are protected even as their hormones are really declining significantly and then drop from the previous hormones. I call it like their health savings accounts. They're living on their savings, so to speak, even though they're not earning anything new. They're not putting out any new hormones, but they're living off their savings, and it keeps them going for a while. Because when you look at when women really start to manifest problems, unless they were previously very unhealthy, like they already had hypertension, they already had diabetes, they were very obese, things like that. They had pre-existing, we'll say, medical conditions that are cardiovascular bad things before they even hit menopause. And that's a big segment of the population, unfortunately, these days. They're metabolically unhealthy when they're in the reproductive years. But if you take women that were still reasonably healthy when they went through the menopause, and that's who they studied, okay? They didn't study the metabolically unhealthy. They didn't let them in the study. Those women live off their savings account of health from their previous hormonal stash, and they tend not to start having cardiovascular issues when they're still in their early 50s. That isn't what happens, which is good. But when you're studying women for like 4 years and they're all recently menopausal in their early 50s, how many people are going to show a lot of transitional changes in their arteries during those few years? even if they're not on hormones, not really a lot. In that study, the KEEP study, they did show improvement in that nebulous thing called quality of life.
Right.
They felt better, okay? They lived better, they felt better, but it didn't really get reflected in measurable changes in their arteries. But once again, a little bit of estrogen, this actually proves my premise, if anything else, is that it takes only a whiff of estrogen to make you feel better, but it takes more to keep your cardiovascular system, your musculoskeletal system, your genitourinary system, your neurological systems, to keep those systems optimally functioning. It takes more. It just does. So we need to go back to the drawing board, but nobody's paying for it. No one's interested. So here's the story. We have to live off of and make decisions in the here and now. We can't say, I'm going to wait for someone to come and do a study and then give me the clinical data that I require to make a decision. Well, you won't be around. It'll be way too late for you. So this is reality. It's like before Google Maps. Okay, you don't have a Google Map. You don't have a cell phone. You are driving and you know where you want to go, but you don't know the lay of the land. You don't know the roads, and there's no one around. It's in the middle of the night. The roads are empty. You don't know where you're going. You can do what? And you get to a fork in the road. You can try to figure it out. I don't know, like look at the moon, look at the North Star or something, right? And then you just make your best decision of which direction to go, or you just park and you wait for someone to come and rescue you, which may or may not happen,
Right.
Because it's like a lonely country road. Nobody ever comes by. So that's us. That's us. Now, we either make a decision based on science, or you make no decision, which is do nothing and let your body go its natural way towards aging, which not good, ladies, not good. I wish I could say menopause was the initiation of the healthiest time of a woman's life, but it is not. It is inevitable. Doing nothing, you will have much worse health as the years progress following menopause than before. It is a huge metabolic shift in the body, hugely affecting the cardiovascular system and other systems. You sink or swim as a total unit, your body. Once you embrace and accept the benefits and the functions of estradiol and progesterone, then you have the knowledge and the fortitude and the will to just go on hormones and do the best you can based on the knowledge we have, without giant additional studies, because they're not coming our way, not now, not in the foreseeable future, to make clinical decisions based on science. I mean, that's the best way we can do. And that's what I put in my articles all the time. Here's the science. Here's the science. And then, but inevitably, someone comes back and says, but where's the clinical data? And it's like, it drives me crazy because no one will pay for those studies. So I can't say, well, look at this study that used the proper dosing and the proper rhythm of hormones in the proper population, and here's the outcome. I can't show a study that was never done, will maybe never be done, but what I can show is this is what estradiol does in the artery. This is what it does in the mitochondria. This is what it does with the neurological system, like the autonomic nervous system. This is what it does with the conducting system of the heart. I can go through the different systems that impact cardiovascular health, and I can lay it out. This is what estradiol does. What do we know? We know what happens when you don't have it. We know that women who go into an early menopause have a higher rate of cardiovascular decline. We know these things. We know that when you not have enough estrogen on board, that you're more likely to have all the bad things that happen with cardiovascular events. So we know what happens very well when you don't have it. And we know that women who have it during the reproductive years do well. So if you take, I mean, just like thinking just a little bit, if you have a woman who goes into what would be called early menopause. So officially, menopause is 12 consecutive months without any vaginal bleeding. This is a completely arbitrary, made up diagnosis. And it makes it sound like menopause is about menstrual cycles and periods. Right. And it is not, because a woman who had a hysterectomy also goes through menopause. In fact, I've had that question, like, I had a hysterectomy. Does that mean I don't go through menopause? It's like, no, doesn't work that way. Okay. So it's the uterus is a target of hormones. So the menopause, not having a period, is just a reflection of altered hormone production. It is not the issue. For a woman who went like 10, 11 months and didn't have any bleeding, and then suddenly she starts having bleeding, no doctor in his or her right mind is going to say, look, it's been 10, 11 months. You're not officially in menopause, but now you're having periods again. You're ovulating. No, you can't assume somebody randomly is starting to ovulate after 10, 11 months of no bleeding. You would assume that abnormal bleeding, like what's going on in the uterus. Could there be cancer? Could there be hyperplasia? Could you have a polyp? I mean, that is not normal. So this is a crazy arbitrary definition that is really meaningless and harmful, actually, because we have to rethink what is menopause. It's a continuum of ovarian aging and alteration in ovarian hormone production that has widespread effects throughout the body. And yeah, it can change your periods, but that's just one manifestation of hormonal change. So really, it should be called either ovarian senescence, aging ovaries, whatever. But menopause is completely a bad term for what's going on in a woman's body. And also, by the time a woman goes 12 months and has no bleeding spontaneously of any sort, whatever is causing the bleeding, that's late in the game.
Right, right.
That is not an early manifestation of hormonal decline. That is late. So when we think of it as a continuum of ovarian aging, like everything else in medicine, we want to be proactive. That's why they keep changing the names of medical conditions to make them more proactive in terms of taking steps. Like now we have a condition called prehypertension. So we don't wait until someone has a blood pressure of 200 over 120. That's like the comparable to now you haven't had a period for 12 months or bleeding, whatever. That's like, oh, now your blood pressure finally reached 200 over 120. Now we'll consider treatment. No, we consider treating at pre-hypertension. Now we have pre-diabetes, and we have now even pre-diabetes, which is just insulin resistance, right? We want to get on things early. We don't want to wait until we're late stage disease. That's what medicine is supposed to be about, being proactive and preventative. So we have to think of treating women who are in the earlier stages, because we now know we have tons of data on what happens in menopause, okay? What we don't have are the clinical studies giving bioidentical hormones for years and seeing what happens using the right doses and the right forms, because nobody cares to do it because it's just not popular in the mainstream medicine yet. It will be, but not, I don't know when, but we girls who are here at this stage in life, we cannot wait.
Thanks for listening to Menopause Rescue. We hope you've enjoyed this podcast and it helps you create some time and space to make this the best half of your life. If you've enjoyed this content, please leave us a 5-star rating and review. This helps other listeners find this resource and rescue and restore their health. If you enjoyed this topic and want to learn more, check out our resource guide for this episode. If today's podcast resonated with you and you want to take a deeper dive, check out my educational resources. We offer basic membership, which is an archive of over 100 videos on menopausal topics ranging from bone health to libido. We add to this archive every month, so the resource becomes richer and richer over time. If you're looking for a menopause expert and live in North Carolina, take our free online class and see if we're a match for your needs. It's called Are We a Good Fit? and is a quick and easy way to learn more about our practice and what it has to offer. Hey, this is Dr. Watson. This is just a friendly reminder that this podcast is for general information purposes only and does not constitute the practice of medicine. No doctor-patient relationship is formed, and any information you get from this podcast is considered educational only. You should make medical decisions with your healthcare provider